I want you to picture something in your mind's eye for a second.
Mm.
Imagine a split screen, right? Just stark black and white.
Okay.
On the left side of this screen, picture this towering, gleaming, modern hospital building. It's got, a helicopter pad on the roof, pristine glass walls, surgical suites filled with, like, the most advanced diagnostic machines on Earth.
The absolute peak of modern medicine.
Exactly. Now, on the right side of the screen, I want you to picture a rutted, washed-out dirt road. It's winding into this remote, deeply impoverished rural village. No power lines, no running water.
Right. A totally different world.
Yeah, and right in the middle of these two images, I want you to place a massive, bright red question mark. Just hang in there.
It really is the defining visual of our modern era, honestly.
It is. And the question behind that visual is, why do some societies seem absolutely destined to just become more and more fractured? Because when we talk about the wealth gap today, we usually point to bank accounts.
We look at stock portfolios or real estate.
Right?
Yeah.
We look at the zip code someone lives in. We look at the end results of, like, a lifetime of inequality. But the truth is far more unsettling. The most lethal gap between the rich and the poor doesn't start when someone applies for a job.
No, it doesn't.
It doesn't even start when they enter kindergarten. It actually starts in the womb.
It's pulled wide open before life even officially begins. And, we often fall into this trap of thinking that healthcare inequality is simply a transactional problem.
Yeah, paying for groceries.
Exactly. We assume it's just about money. The prevailing logic is, well, if you have money, you buy medical care. If you don't have money, you can't.
It sounds logical on paper.
It does. But the reality is vastly more complicated and, frankly, a lot more insidious than just a simple lack of funds. Healthcare access is actually a reflection of the invisible folding structures of society.
Which is wild to think about.
It is. It's about geography, education, cultural capital. It's an entire hidden architecture that dictates who lives, who dies, and who is allowed to even realize they're in danger in the first place.
So, welcome to the deep dive. Our mission today is heavy, but it is absolutely vital to understanding how our world actually operates. We are going to deconstruct how society breaks apart at the seams.
You have to.
We really do. We're going to look at why the destiny of the poorest individuals is so often completely sealed before they take their first breath.
And to do this, we aren't going to rely on anecdotes or, political rhetoric. We are looking at a landmark 2009 working paper. It's from the National Bureau of Economic Research.
The NBER.
Right. Authored by MIT economist Jeffrey E. Harris and Mexican scholar Sandra G. Sosa-Rubi. And let's establish the tone right now, right out of the gate. This isn't a dry academic discussion about healthcare economics.
No, definitely not.
Or just boring statistical modeling.
Far from it. We are going on a forensic examination of a societal black hole. We are going to use hardcore data to peel back the cruel realities of how human lives are categorized.
And how the state attempts to intervene.
Exactly. And to really understand this invisible architecture, we have to travel back a bit in time. So we're going to Mexico, and the year is 2001.
The historical context here is so critical because Mexico in 2001 was facing what you might call the late-stage anxiety of a developing nation.
What was the atmosphere like?
Well, you had a society that was fundamentally and geographically fractured. I mean, if you looked at a demographic data map of the country at that time, it essentially depicted two completely different planets coexisting within the exact same national borders.
As living side by side.
Exactly. Exactly. Half of the entire population was completely cut off from the modern medical system.
Wait, half? 50%.
50% entirely cut off.
That is a staggering proportion to wrap your head around. I mean, we aren't talking about a marginalized 1% here or some small neglected pocket of a city. We're talking about half the country living in a massive dark gray area on the map.
Totally uninsured.
It's wild.
And the divide was incredibly stark. In the wealthy urban centers, places like Mexico City or Monterrey, those populations enjoyed world-class private healthcare facilities.
So they had the left side of our split screen.
Exactly. They had access to top-tier specialists, modern obstetrics, cutting-edge neonatal care. Meanwhile, the rural poor, especially those living in indigenous communities or, deeply marginalized agricultural areas, they were left entirely to fend for themselves.
So, okay, what did that actually look like for a pregnant woman in that specific demographic? Because if she has no insurance and no access to a hospital, she doesn't just stop being pregnant.
Right.
How is she managing this incredibly vulnerable period of human life?
She relied entirely on informal networks. She might seek out traditional healers or, a local partera, a traditional midwife, if she was fortunate enough to even have one in her village.
And if she wasn't,
In many cases, she simply suffered in silence. The data from that era shows it was entirely common for a woman to go through her entire 40-week pregnancy without ever seeing a single licensed medical professional before going into labor.
wow, 40 weeks. That is a total disconnect from the safety net of modernity. Like, if something goes wrong, if her blood pressure spikes, if the baby is positioned incorrectly, there's just no one to catch her.
None. There was no safety net. It was a calcified class structure, hardened over generations. But, the Mexican government at the time, to their credit, they recognized that this was an unsustainable and deadly status quo.
They saw the crisis.
They did. The loss of human capital, the maternal mortality rates, the sheer inequality. It was threatening the stability of the entire nation. So they launched a massive, audacious project to try and break this deadlock.
And this was called Seguro Popular.
Right, which translates to people's insurance.
And the pitch for Seguro Popular was incredibly straightforward, wasn't it? I mean, it sounded like a perfect Snager narrative, the kind of policy you read about in a press release and just immediately applauded.
Oh, absolutely. The government essentially broadcast a message to the bottom 50% of their citizens. They said, if you are uninsured and poor, join us, sign up for this program, and the government will foot the bill for your health care.
Just like that.
Just like that. They rolled it out starting in 2001 as a pilot program for just 5 states. But by 2005, through really aggressive expansion, it had spread across all 32 states of Mexico.
So a massive, rapid rollout.
Very rapid. And it provided a very specifically defined package of benefits, explicitly targeting maternal and reproductive health. The goal was to pull those marginalized pregnant women out of the shadows and into the modern clinical era.
But see, whenever a government launches a program of this magnitude, my alarm bells start ringing immediately.
Oh, sure. As they should.
Right. Because we are talking about pouring billions of dollars of public money into a system. And that brings us to the core conflict of any grand social experiment. Think of it like a giant funnel.
Okay, a funnel.
The government is pouring endless resources into the top of this funnel. But at the bottom, there are 2 different pipes the water can flow out of. How do we actually know if a policy like this is working?
That is the essential question. How do you measure human behavior when big money is involved?
Let's use an analogy to break this down for you guys listening. Imagine you want to improve the physical fitness of a neighborhood. So you hand out thousands of free gym passes to the residents.
I like this.
Right. So a month later, you look inside the local gym and it is absolutely packed. People are on the treadmills, they're lifting weights, they're attending classes. As the policymaker, you might look at that and think, wow, my policy was a massive success. Look at all these fit people. I made them fit.
But there is a glaring logical flaw there.
Exactly. Did those free passes actually make anyone fit? Or did the people who already care deeply about their health, the ones who were already planning to work out anyway, just grab the freebies to save themselves a few bucks?
That is a brilliant way to frame it. The people who were already motivated simply subsidized their existing behavior,
Right.
while the people sitting on the couch at home, the exact ones you actually needed to read, are still just sitting on the couch.
Nothing changed for them.
Nothing. In econometrics, we have a specific term for your gym pass problem. It's called endogeneity. Specifically, we are talking about self-selection bias.
Self-selection bias, meaning the participants chose themselves based on traits we can't necessarily see on a spreadsheet.
Precisely. And it is the statistical black hole where countless poverty elimination policies go to die.
That's grim.
But it's true, because here's what actually happened in Mexico. After Seguro Popular rolled out, the raw data showed that prenatal checkups skyrocketed. The top-line numbers looked fantastic. The clinics were full.
Just like the gym.
Just like the gym. But the researchers, Harris and Sosa-Rubi, they were forced to ask the hard, really uncomfortable question. Were these pregnant women going to the doctor because of the free insurance? Or were these specific women already health conscious?
Did they already have a plan?
Right. Did they already possess a certain level of education, agency, family support, meaning they were going to find a way to get to a doctor regardless of the government program?
Because if they were going to go anyway, then the policy didn't actually alter their destiny. It just picked up the tab.
And the stakes for answering this question are astronomically high. If we cannot separate true cause and effect from the just chaotic statistical noise of human behavior, those billions of dollars of public money might just be rewarding people who already had the baseline resources.
Or the knowledge to seek help.
Exactly. Meanwhile, the truly marginalized, the women living at the end of that dirt road we pictured earlier, the people the policy was explicitly designed to save, might still be out in the cold, completely untouched by the state's intervention.
So the true tragedy wouldn't just be a failed policy. The tragedy is that we might not even possess the mathematical tools to know that it failed. If we only look at the average number of people in the waiting room, we are blinding ourselves.
That average is a massive blind spot.
I think we need to emphasize a really counterintuitive truth here for you listening.
Yeah.
The average is often a lie.
The average smooths over all the critical nuances of human suffering.
It does. When most people think of wealth and poverty, we tend to imagine a continuous ladder. You have the poorest folks on the bottom rung, the working class above them, the middle class in the middle, and the wealthy at the top. We assume everyone is connected to the same structural framework, just at different heights.
That's the common perception.
But the data in this study proves something terrifying. Society isn't a ladder. It is already fractured into completely isolated islands.
Parallel worlds.
Yes, parallel worlds that do not touch and honestly do not even realize the others exist.
And to prove that these parallel worlds existed, Harris and Sosa-Rubi had to do something statistically brilliant. They knew they couldn't just look at the overall average because, like you said, averages smear everything into one gray blob.
Right.
Instead, they built what we can think of as a mathematical societal X-ray.
A societal X-ray. Okay, before we get into how the machine works, let's talk about what they were actually scanning. Where did they get the data to see these invisible structures?
They utilized a massive cross-sectional data set from the 2006 National Survey of Health and Nutrition in Mexico. It's known as the NSANUT survey. And we really have to appreciate the sheer human effort behind this data. This wasn't just like an online poll.
Right, they didn't just email a survey link.
No, this involved field researchers physically traveling across the country, driving up those unpaved mountain roads, walking into rural villages, and sitting down in dirt floor kitchens to interview citizens face to face.
Wow. They were knocking on doors, speaking to people in their own homes, asking incredibly intimate questions.
Yes. And from this massive national survey, the researchers isolated a specific group. 4,381 women who had given birth between the years 2002 and 2005.
So right in the thick of the rollout.
Exactly. This window perfectly captured the rollout phase of Seguro Popular, and the survey provided incredibly granular, detailed data on these 4,381 women. They didn't just ask, hey, how many times did you have the doctor?
What else did they ask?
They recorded their age, their highest level of education, the material of their home's floor.
The floor material.
Yes, whether it was dirt, wood, or tile, whether they had running water, if they spoke an indigenous language rather than Spanish, their history of prior pregnancy losses, and a full index of their household assets.
So they gathered every tiny thread of these women's existences.
Yeah.
But how do you take all of those disparate threads, like a dirt floor here, a high school diploma there, an indigenous dialect, and solve the gym pass problem?
Right, the endogeneity.
Yeah, how do you strip away the self-selection bias using that?
That is where the societal X-ray comes in. In academic terms, they used a latent class model utilizing a specific statistical algorithm. But we can understand it much more clearly through an analogy. Imagine you have a prism, like a glass triangle.
Okay, a prism.
If you shine a chaotic, blinding beam of white light into that prism, what happens?
Well, the prism bends the light. It mathematically separates that chaotic white beam out into a perfectly distinct rainbow of individual colors.
Exactly. The algorithm works just like that prism. You feed the chaotic, noisy data of 4,381 individual human lives into the model. It processes all those variables, the education, the floors, the doctor visits, the insurance status, and it mathematically separates the population into distinct, unobservable groupings.
That's fascinating.
It's incredible. It strips away the self-selection bias. It controls for the fact that a wealthier woman might naturally seek more care. And when the math settled, it identified hidden classes of people who shared underlying invisible traits.
It found the islands.
It did. It perfectly stripped away the noise and revealed 3 distinct parallel worlds of pregnant women living in Mexico at that time. And it's crucial to understand here. The researchers did not create these categories beforehand.
So they didn't force the data into pre-made boxes.
No. They didn't say, let's divide them into poor, middle, and rich. The mathematics organically discovered these 3 distinct ecosystems hiding inside the data.
Let's explore these 3 worlds. Because when you look at the characteristics of these islands, it is deeply unsettling. Let's start with World 1, the bottom of the slide, so to speak. We can call them the silent extreme minority.
Okay, if you were to chart this out visually on a graph, World 1 is a tight cluster of data points huddled right at the absolute bottom left corner, hovering perilously close to zero. This group makes up just 5.14% of the population of pregnant women in the study.
A tiny fraction, just over 5%.
But their daily reality is an abyss. On average, a woman living in this parallel world has a microscopic 0.52 prenatal visits across her entire 40-week pregnancy.
Wait, half of a visit.
Half of a visit average.
Which means, practically speaking, the vast majority of these women are having exactly one visit, or zero.
That's the darkest part of the data right there. It revealed that a shocking 3.22% of all women in the survey had exactly zero prenatal visits.
I really want you listening to sit with that statistic for a second. Think about an entire human gestation. 40 weeks of profound physical transformation. The body is shifting, organs are moving, hormones are surging. It is a period rife with potential life-threatening complications.
Truly life or death.
And these women are creating a new human life without a single interaction with a medical professional.
Wow.
No blood pressure checks,
Yeah.
no heart rate monitors, no nutritional advice, nothing.
Nothing at all.
Yeah.
And we cannot treat this as just a cold number on a spreadsheet.
Yeah.
The PRISM model tells us exactly who these women are. They are women with almost zero formal education. They live in highly remote, highly rural localities with severe deprivation indices.
Yeah, deep poverty.
Extreme. This means their daily life involves living with dirt floors, no municipal electricity, and carrying water from a well or river. Furthermore, they frequently only speak an indigenous language, which acts as a massive wall isolating them from the Spanish-speaking medical establishment.
They are completely locked out of the modern era.
They are, and the true tragedy of World 1 isn't simply the absence of medical care. The tragedy is that they have been structurally stripped of the very ability to cry for help.
What do you mean?
I mean, they lack the paved roads to travel to a clinic, they lack the money for bus fare, they lack the Spanish vocabulary to fill out an intake form, and they lack the institutional knowledge to even demand entry into the healthcare system. They are entirely silent, suffering behind an invisible wall.
Wow, that is heavy. That's the absolute bottom of the societal fold. So from that dark corner, let's step across the void into World 2. We'll call this group the mediocre majority.
If World 1 was a tiny, tragic cluster at the bottom left, World 2 is the massive, towering bell curve right in the center of our chart. This group swallows up the vast bulk of the country. They represent 88.14% of the population.
So almost 9 out of every 10 pregnant women fall into this second world.
Correct. These are relatively normal women with basic societal resources. They aren't living in luxury, but they aren't living in the extreme isolated poverty of World 1 either.
They have the basics.
Right. They have a roof over their heads, they likely have some level of high school education, and they have geographical access to a clinic or hospital. And crucially, according to the data, they have no obvious severe medical complications.
So what does their prenatal care look like? If they have access, are they actually utilizing it?
They are. On average, a woman in World 2 has 7.33 prenatal visits during her pregnancy.
So about 7 visits. That equates to roughly 1 visit every 5 weeks. That sounds perfectly normal. It sounds like a functioning, rational healthcare system.
It is the stable core of the society. They get their routine checkups, they take their vitamins, they have their babies, and the system works for them. They represent that illusion of the average we discussed earlier.
It's the blind spot.
Yes. If a politician or a traditional health economist only looked at World 2, they would declare the healthcare system a resounding success.
But they are masking a massive hidden crisis. Because there is a third world, and this is where the data completely defies expectation. World 3. Let's call them the survivors on the edge of the cliff.
This is where the cognitive dissonance of the study really hits you, because World 3 is another very small group representing just 6.72% of the population. But if you look at their data on our imaginary chart, the line doesn't just bump up slightly from the average.
It shoots up.
It skyrockets. It shoots straight up like a rocket. These women are averaging a staggering 16.84 prenatal visits.
Almost 17 doctor visits for a single pregnancy. That means they're going to the hospital or clinic roughly every 2.5 weeks for 9 straight months. Now, if I am looking at this without the prism, my immediate hypothesis is simple. I'd assume these are just the wealthy elite. I would guess these are wealthy urban women who have private concierge doctors on speed dial, and they just go in for a scan every time they feel a slight backache. Is that what World 3 is?
That is exactly what common sense and honestly many traditional economic models would tell you. If someone is consuming 17 doctor visits, you just assume they are over-consuming resources simply because they can afford to do so.
Right. It's a luxury.
But here is the profound truth that the algorithm uncovered. No, these women are not visiting the hospital constantly for fun or for, like, routine 3D ultrasounds. They are going 17 times because they have severe, life-threatening complications.
Wait, really? The data proved they were sick?
The math isolated them perfectly. They are fighting for their lives and the lives of their unborn children right on the edge of a cliff.
Oh, wow.
The dataset showed that this specific group had incredibly high rates of pre-existing and gestational conditions. We are talking about severe diabetes, hypertension, life-threatening urinary tract infections, and preeclampsia.
So these are extremely high-risk pregnancies.
Extremely. They require constant intensive medical management just to prevent maternal or fetal death.
So society isn't a ladder at all. It is actually split into 3 distinct islands that operate on completely different rules. Island 1, the marginalized and invisible, receiving absolutely zero care. Island 2, the massive healthy middle class receiving normal routine care. And Island 3, the high-risk group fighting for survival with constant intensive medical intervention.
The societal X-ray is complete. We can finally see the invisible structures that dictate healthcare.
So now that we have the map, we have to ask, what did the policy actually do? The Mexican government dropped billions of dollars to give out free health insurance through Seguro Popular. When you look at the raw top-line data, what changed?
The raw average showed an overall increase of 1.65 prenatal visits per enrolled woman.
So roughly 1.5 extra visits on average. Now, if we rely on common sense again, we naturally assume this means the policy acted like a rising tide that lifted all boats equally.
Which is the normal assumption.
Right. We assume the woman in World 2 who used to go 7 times now goes 8 or 9 times. We assume the woman in World 1 who went 0 times now goes 1 time. It's a nice even spread across the population.
But the X-ray reveals that assumption is entirely false. And this completely subverts how we think about public policy. That 1.65 average increase is not an even spread at all. It is actually the statistical footprint of a massive seismic class migration.
A class migration? What do you mean by that? How do you migrate classes in healthcare?
Well, Harris and Sosa-Rubi used their model to decompose that 1.65 number, right, to trace exactly where those extra visits came from. And they found what I can only describe as a statistical miracle. They discovered that 59% of that overall statistical increase happened because women in World 1, that silent abyss of extreme poverty, successfully broke through the class barrier and stepped into World 2.
Hold on. So it wasn't just adding one random visit to everyone's schedule.
Yeah.
The policy took a massive chunk of women who were getting absolutely zero care, women who were destined to give birth on a dirt floor with no medical help whatsoever, and gave them the power to act exactly like the middle class.
Precisely. The math proves that Seguro Popular provided the exact logistical and financial catalyst needed for these women to cross the void. Because they finally had insurance, they found the means to travel to the clinic.
They could actually go.
For the very first time in their family's history, they walked through the doors of a modern medical facility. They didn't just get one visit. They started receiving the 7 or 8 visits that constitute standard life-saving modern care.
That is amazing.
This policy literally dragged them out of the dark ages. That monumental shift accounts for 59% of the policy's entire impact.
That is an incredible triumph. But let's look at the remaining numbers. Because if 59% of the impact was culling the bottom island onto the middle island, where did the other 41% of the policy's impact go? When I read this part of the study, I really couldn't believe what I was seeing.
This is the ultimate plot twist of the research. The remaining 41% of this statistical increase was driven by pushing women from World 2, the mediocre, supposedly healthy majority, into World 3.
Let me stop you right there, because World 3 is the intensive care group.
Yes, it is.
That is the high-risk, edge-of-the-cliff group that needs 17 visits just to survive. So the data says that government insurance policy took healthy middle-class women and pushed them into the severe complication group.
That's what the math shows.
If I'm interpreting that, it sounds like the policy made people sick. Did the hospitals infect them? Did the policy harm them?
At first glance, that is exactly what the data implies, and it sounds like a catastrophic failure. But the incredible, deeply ironic, and profound truth is this. No, the policy did not manufacture patients.
Okay, good.
It didn't make a single person sick. Those women in World 2 already had life-threatening complications. But they didn't know it.
They were completely unaware.
They were walking around with gestational diabetes or severe hypertension or undiagnosed preeclampsia. But because they only had the resources or the out-of-pocket cash to go in for routine, sparse checkups, those complex conditions were completely invisible to them and invisible to their doctors.
They were ticking time bombs.
Exactly.
And Seguro Popular changed the dynamic of their care.
It did. Seguro Popular changed the financial incentives. It gave the women the financial freedom to seek more thorough diagnostics without fearing bankruptcy. And it incentivized the rural clinics to look closer, to run the blood panels, to do the extra ultrasounds, because now the government was paying for it.
The hospital could afford to test them.
Right. It gave these women the means to be diagnosed before it was too late.
So once the doctor finally identifies the hidden complication, that woman's reality shifts.
Yes. Statistically, she migrates from World 2 into World 3. She goes from having a casual 7 visits to having 16 intensive visits because now she's being actively, aggressively managed by the medical system to keep her and her baby alive.
That completely changes the narrative of what insurance actually does.
Yeah.
I mean, the policy didn't just give poor people a free ticket to the clinic. It handed invisible, high-risk women a literal lifeline.
It illuminated the darkness.
If they hadn't received that insurance, those women would have just stayed in World 2, entirely oblivious to their own failing health until the day they went into labor and their bodies crashed.
It's a staggering realization, and this brings up a massive point about how society evaluates public policy. Because if this study is so brilliant, if it uncovered this miraculous life-saving dynamic, why did traditional analysts miss it entirely?
That's a great question, because Harris and Sosa-Rubi weren't the first people to evaluate Seguro Popular, were they? The Mexican government had traditional economists and health analysts running standard reports on this policy for years.
They sure did.
So why were they completely blind to these three worlds?
They were blind because of the arrogance of traditional mathematics. Remember our gym pass analogy?
The endogeneity problem.
Yes, the problem of self-selection bias. Traditional evaluation models simply ignored it. They didn't account for the fact that human beings are complex and that women self-select into insurance programs based on unseen traits.
They just looked at the raw, top-level numbers and assumed that told the whole story.
Exactly. And the researchers actually prove this in the paper. They ran the data using the traditional, flawed methods just to show exactly how wrong the old guard was. They refer to it as Model B in the paper.
What happened with Model B?
When you ignore the gym pass problem, when you fail to account for endogeneity, Model B underestimated the policy's life-saving impact by a massive 21%.
A 21% shrink in the perceived effectiveness of the policy.
Yep.
When you were talking about billions of dollars and thousands of human lives, missing 21% of the impact is a colossal failure of analysis.
And the traditional arrogance gets even worse. They also ran something called Model C, which is a standard two-class model. A lot of analysts, politicians, and journalists love to divide society into two simple buckets: the haves and the have-nots.
The insured and the uninsured. The rich and the poor.
It sounds perfectly logical on the surface. It makes for an easy headline.
But human suffering doesn't fit into two neat buckets.
No, it doesn't. When traditional analysts force this complex data into a two-class model, the math completely failed to even see World 3. The simplified model predicted that one group was getting about 1.4 visits and the other group was getting about 7.7 visits.
Wait, what about the women getting 17 visits?
Con. The high-risk women, the women surviving on the edge of the cliff, receiving 16 or 17 visits to save their lives, were mathematically erased from existence. They were just blended into the average.
That is honestly terrifying, because it implies that right now, all over the world, countless policies designed to help the bottom of society are probably being deemed ineffective by arrogant, standardized reports. Politicians might be defunding life-saving programs simply because their math isn't sensitive enough to see the actual human beings whose lives were saved.
Precisely. If you only look at the surface average, you miss the tectonic shifts happening underneath. You erase the social folding. And speaking of the way society folds, there is another deeply uncomfortable revelation hiding in the demographics of World 3 that we must address.
I want to hear it. What else did the X-ray show us about these women on the cliff?
We need to dig into the correlation between wealth, education, and disease. When Harris and Sosa-Rubi looked at the specific factors that pushed a woman into World 3, the high-risk, high-visit group, they found a trend that seems completely backwards.
Backwards how?
The data shows an incredibly strong positive correlation. The more educated a woman is and the wealthier her household is, the more likely she is to be categorized into the high-risk group.
Okay, wait. Let me push back on this because that goes against everything we know about public health. You are saying the data shows that going to high school, having a paved floor, and having a higher household asset index makes you more likely to have severe, life-threatening pregnancy complications.
It sounds insane, right?
Are we saying that being rich and educated actually ruins your physical health?
I know, it sounds entirely absurd. But we have to deliver another massive blow to our assumptions here. No, wealth and education do not make you sicker. Wealth and education grant you the privilege of recognizing the crisis.
Privilege as a diagnostic tool.
Exactly. Think about the daunting reality of navigating a modern medical system. It is intimidating. A wealthier, more educated woman has the vocabulary and the confidence to understand a doctor's nuanced warning.
She speaks the language.
Yes. When the doctor says, your blood pressure is slightly elevated and there is protein in your urine, I want you back here in 3 days, the educated woman understands the unspoken threat of preeclampsia. Furthermore, she actually has the logistical resources, the personal vehicle, the ability to take time off work, the money for childcare for her other kids, to actually afford those frequent, intensive return trips.
And contrast that with the woman in World I or World II. She might sit in the exact same exam room and hear the exact same warning from the doctor.
Right.
But she literally cannot parse the clinical jargon. Or even if she understands the danger, she simply cannot afford to miss another day of agricultural work to ride a bus for 3 hours each way. So she nods politely, leaves the clinic, and doesn't come back until she's actively hemorrhaging.
That is the brutal, unfiltered truth of healthcare inequality. The model reveals that poverty isn't just a lack of money, it is a lack of cognitive and logistical access.
The system is rigged against them.
The reason there is a negative correlation for poorer, less educated women moving into World 3 isn't because poor women are magically healthier, it's because they are locked out of the diagnosis. The most terrifying aspect of poverty isn't getting sick. It is being terminally ill and not even knowing it because society hasn't given you the tools to see your own destruction.
The arrogance of this system is believing that access just means an open beer at the clinic. Like, look, the clinic is free, the door is open. But if you don't have the key, which is education, transportation, and wealth, that open door means absolutely nothing.
And this brings us to the ultimate reckoning of the entire deep dive. We've seen how brilliant this policy was at dragging people across these invisible lines, pulling them from World 1 to 2 and from 2 to 3. But we have to talk about the cost of changing the world.
Let's talk about it.
Because in modern politics, we love the idea of cheap, easy fixes. We love the silver bullet.
Right. We want to believe that you just pass a law, sign a piece of paper in a capital city, and boom, poverty is solved. The marginalized are saved. But the universe doesn't work that way, does it?
It doesn't. The researchers didn't just pat the government on the back. They broke down the brute force economics required to actually move the needle. They calculated something called the policy-relevant treatment effect.
Okay. What does that mean in plain terms?
In plain terms, what actually happens when a local government flexes its muscle and pushes hard to get people enrolled in Seguro Popular? What is the cost if they try to increase the local penetration of the program by 10 percentage points?
10% more people covered in a local area. That sounds like a solid, achievable goal for a mayor or a governor. What is the payoff for that effort?
The math is unforgiving. To achieve a 10% increase in Seguro Popular penetration, it only generates a microscopic 0.139 average increase in prenatal visits across the population.
Wait, 0.139 visits.
Yeah.
That is a tiny fraction of a single doctor's appointment. It feels almost statistically insignificant. Why such a small bump for a 10% increase in coverage?
Because of how deeply entrenched the barriers are. And to get that tiny 0.139 bump, it required a massive mobilization of state power. It wasn't just like printing some flyers and taping them to a wall.
What did it take?
The researchers looked at the budgetary data from 2006. They found that the government had to invest roughly $526 per household into local infrastructure and outreach just to get that 10% bump.
Let me make sure I'm understanding this. $526 and $2,006 per household. In rural Mexico, where many families are surviving on dollars a day, that is an astronomical sum of money. What exactly are they spending that $526 on?
It wasn't just going into the pockets of the patients. That money had to be spent on the brute mechanics of tearing down World 1.
How do you tear down?
It meant buying 4x4 vehicles to send health workers up unpaved mountain roads. It meant paying rural stipends or hazard pay to convince doctors to leave the wealthy cities and work in remote clinics. It meant printing medical materials and hiring translators for indigenous dialects like Nahuatl or Maya. It meant physically building clinics, running generators, and subsidizing the massive administrative overhead of finding invisible people.
The cost to change the world is staggeringly high. It requires an overwhelming amount of capital and effort. It is like using a lever with a terrible fulcrum. You lean on it with all the financial might of the state, and the needle barely twitches 0.139 spaces.
Exactly. A cynical politician might look at that $526 price tag, look at the 0.139 visit increase, and say, this is a failure, it's a waste of money, shut the program down.
But, and this is the massive but that makes this entire study so important, we just spent the last hour explaining why that tiny decimal is an illusion.
Yes, it's a total illusion.
That 0.139 isn't just a speck of dust on a spreadsheet. Because we have the X-ray, because we now know about the three worlds, we know exactly what that decimal actually represents in human terms.
If that money isn't spent, if the state looks at the $526 price tag and decides it isn't worth it, what happens?
The darkness wins.
That small statistical decimal translates to real, impoverished mothers in World I bleeding to death on dirt floors because a doctor never reached them. It translates to women in World II dying of undetected eclampsia because the clinic couldn't afford to run a simple diagnostic test.
You cannot put a price tag on that. You just can't.
You can't. And this leads us to a profound synthesis about the true nature of the state machine. What does this Mexican healthcare experiment really teach us about human governance and policy?
It teaches us that governance cannot be passive.
Precisely. Public policy isn't just about balancing budgets or managing inflation. True public policy is a forceful, almost violent intervention into the natural folding of human life.
A violent intervention.
Because by default, capital and power naturally centralize. Resources flow up, not down. Good doctors move to wealthy cities. Hospitals are built where people can pay. Without the institutional machine actively, expensively, and forcefully tearing down those invisible class barriers, the poorest are invariably left in the dark.
The system, left to its own devices, naturally wants to create World I. It wants to isolate the weak because it's economically efficient to ignore them.
Yes. A true policy, a truly moral intervention like Seguro Popular at its absolute best, isn't just a welfare handout. It is the state using its massive leverage to fight gravity. It is the government intervening to give the marginalized the right to be free from fear, free from ignorance, and free from dying simply because they were poor.
I think that is the perfect way to encapsulate this entire journey. We started by looking at a confusing statistical black hole, the Jim Pass problem, the self-selection bias. But by using an advanced algorithm like a prism, Harris and Sosa-Rubi completely deconstructed the invisible architecture of a society. They used complex mathematics not to abstract human suffering, but to perfectly illuminate it.
They made the invisible visible.
They found the silent extreme minority with zero care. They found the mediocre majority masking a hidden crisis. And they found the survivors on the edge of the cliff fighting for their lives. And they proved that a policy doesn't just increase an average, it literally pulls people across the void. It grants them the privilege of a diagnosis.
It is a masterful piece of research because it demands that we stop looking at the surface. It demands that we use our most advanced cognitive and mathematical tools to look into the dark corners where traditional experts refuse to look.
And that leaves me with a final provocative thought, something I want you, the listener, to mull over long after this audio stops. This study we dissected today took place over 2 decades ago, in the early 2000s in Mexico. It took immense political will, billions of dollars, and advanced statistical algorithms just to see the divide in basic prenatal care, let alone attempt to fix it. But look at the world we live in today.
It's moving so much faster.
It is. We aren't just dealing with a gap in basic clinic visits anymore. With the hyper-monopolization of advanced technology, the explosion of artificial intelligence, and the dawn of personalized genetic engineering and biotech, the wealth gap is accelerating at warp speed.
It's terrifying to think about.
Are we currently, right now, creating a new World I? Are we creating a new class of people who will be entirely cut off from the core cognitive and biological advancements of our era? When resources concentrate again, and they always do, gravity always pulls wealth upward. Will we have the courage, the algorithms, and the humanity to build a new safety net? Or is history just preparing to repeat itself, leaving a new generation to suffer in silence, invisible to the average? Thank you for taking the deep dive with us. We will see you in the murky waters next time.